I'd now like to invite Pierre-Thomas Léger to come up. Dr. Léger is an associate professor at the Institute of Applied Economics at HEC Montréal, where he holds a professorship in health economics. He has a bachelor's of social science in economics and political science from the University of Ottawa, and an MA and PhD in economics from the University of Western Ontario, my old stomping grounds. Professor Léger specializes in the industrial organization of healthcare, health economics, and applied econometrics, with special emphasis on physician payment mechanisms. One of his current research projects is examining the effects of team-based incentives on cardiologist treatment choices in cardiac catheterization labs. Thank you. Please welcome Dr. Léger.
Well, thank you for the opportunity to speak. So as I don't have to tell anybody in this room, healthcare expenditures are increasing, not only in absolute terms, but they constitute an increasing share of our GDP, of our income. Now, the idea that healthcare costs are increasing is not necessarily a bad thing, right? If we're spending more because we're richer, or we're spending more because the care that we're getting is of greater value, then spending more is a good thing. And so it's not the presence of higher expenditures that necessarily implies that we need to intervene or it's problematic. However, there's a large body of evidence that is growing that suggests that a lot of the increased expenditures that we're seeing are not resulting in better outcomes. So there's a large literature from the medical community, from large-scale studies that show that in a variety of areas we're spending more without getting necessarily more. There's also evidence from a related topic that shows that there's a lot of geographical variation, at least in the US, in spending. And when we compare across these geographical areas, we don't see the corresponding differences in outcomes. So some states are spending way more than other states, and when we control for prices and we control for everything else, the states that are spending 3 times more, i.e. using 3 times more volume, aren't getting 3 times better outcomes. And so both of these sort of these two groups of the literature are suggesting that under the current system, that we might be approaching sort of the flat end of the health curve. Doesn't mean that spending more could not get us more health and more benefit. It's that under the current way of doing things, it doesn't appear that when we spend more, we necessarily get more. Okay. Now, governments are obviously concerned about the inefficiencies because they suggest that either we can do more with what we have or we can do the same amount with less. Okay, so I'll emphasize the first. Let's do more with what we have. And if we free up these resources that are sort of inefficiently used, then we can use them to tackle other areas that we think are problematic, the wait times, the lack of preventive care, and the like. Okay. Now, in wanting to reduce the inefficiencies and to encourage efficiency, we also have to be careful about issues of equity and access to care. So I'm perfectly cognizant of the fact that we just don't want to talk about efficiency, we want to talk about well-being. Now, just for 2 seconds of an aside, if we wanted to tackle some of these inefficiencies, one of the ways that we could do that is to target patients. So there's a large literature that looks at the effects of co-payments, so user fees on healthcare. And the idea is that if patients pay for some of their care, then they might be more responsible in using it. Well, when you bring it to the data and you look at large-scale studies, what we see is that higher co-payments, higher user fees do reduce expenditures, but that's coming essentially because people are reducing their contacts, so they go less to the physician or they are less likely to show up. But the part that's more problematic is once they do show up, these user fees have no effect on the amount of care that's going to be consumed. So yes, it affects it at the extensive margin, but once you're in hospital, how much you pay is not going to affect the amount that you're going to get. And so the other thing that's problematic is that when you sort of dig and look where people are reducing their care when they face higher user fees, they actually decrease as much the effective care than the ineffective care. So it's not that they're necessarily dropping off the stuff that has little value and keeping the stuff that has great value. It's that they're decreasing all types of care. And if you look at the effects of these co-payments on health outcomes in the long term, it's true for the average person that it doesn't appear to have any effect. However, for certain groups, i.e. the chronically ill or the poor, it does have a health effect. And so we would really, not only is it likely to be ineffective to target patients, we might not get the outcomes. We might be suffering outcomes if we see reductions in consumption and expenditures. So instead of targeting the patients, the discussion here is about targeting the financial incentives to physicians. Okay? Now, there's a series of reasons why, at least theoretically, physicians or healthcare providers are seen as a better source or a better target, and that's for simple reasons. First of all, healthcare providers have better information about the patient's illness and the different types of care to provide than does a patient. And so when you want to make clinical decisions at the margin, maybe you would like that to be done by an expert and not just a patient. Okay? The second thing is that healthcare providers have better access to actually the cost information of care. Ask a Canadian citizen what it costs to do an MRI or to have a knee surgery or the like. They're unlikely to know the prices, and so it's very difficult to ask people to make efficient decisions if they don't even see the prices of things. And finally, and it's a small point, healthcare providers are seen, at least collectively or over a group practice, to be able to absorb the financial risk that an individual patient could not. So if, let's say, we put in a co-payment, a user fee, and that user fee could be potentially large, well, individuals would face a lot of financial risks, and that might be problematic. And so physicians with their entire group are likely to be able to manage that risk better. Now, if we're going to target physicians, this might be a theoretical exercise and we write down all these complicated models, but you know, the question is, at the end of the day, do physicians respond to financial incentives? And so the answer to that appears to be, and there's a growing amount of literature on large-scale studies in a variety of areas that show that quite clearly that physicians do respond to financial incentives. Or disincentives, if you prefer that word, and so it's not just a theoretical exercise. Okay? And throughout this, I'll be citing a lot of the empirical literature to back up this claim. So now, before I'm going to discuss about what I think is a really interesting option for Canada, I just want to take a few minutes to provide some background on the different payment options. So the first thing is that the fee-for-service system is the payment system that yes, has decreased in popularity, but still constitutes the most important payment mechanism in Canada and in a lot of countries. So it's true that fee-for-service systems are less popular, but they're still out there and they're still very important. Now, what is a fee-for-service? It's essentially a payment for each service the physician provides that reimburses all of the cost and provides a margin. So I treat a patient, I then have a cost associated with that, I have a fee associated with that, and so I pocket the difference. Okay, so there's no risk with respect to, for physicians. Your revenue is quite simply the price, the fee that you receive times the quantity that you are going to produce. Okay? Now, given that your revenue is simply the fee you receive times the quantity you produce, the only thing that the fee-for-service system rewards is volume. Okay? And so the only way that you can increase your income is to increase this volume, because these prices, these fees are regulated, and you as a physician can't change those. Okay? Now, what are these fee-for-service empirically associated with? Well, the first thing that they're associated with is the phenomenon of supplier-induced demand. So supplier-induced demand simply says that a physician, under a situation of when they have informational advantages, might want to use that informational advantage to manipulate, to encourage certain types of care and discourage certain types of care in order to maximize the revenue. That's the theory. Now, there's a lot of empirical evidence to suggest, and large-scale studies that show that, in fact, in certain areas, including obstetrics and thoracic surgery, where this happens. And so I don't have time to go through all of that, but we could discuss it in if you do not trust these citations. The second thing is that it can actually discourage and actually punish effective treatments and disease management. If I'm a physician who's paid fee-for-service and I'm really good at managing the illnesses of my patients so that they need less care in the future, I'm going to be punished by that because I'm going to make less money. So those that are very effective actually lose out relative to those that would not, that aren't. And so that's a very strong disincentive to manage and things like chronic disease. We also know that it can discourage at the margin the efficient use of specialty in hospital care, but that's really a margin that is not necessarily that important empirically. Now, because the fee-for-service system, which has its positive aspects, but has a negative aspect, which is that it has no incentive for cost control or even cost consciousness, the simple solution would be, well, why not simply pay physicians a capitation rate? Why not go to the opposite end of the spectrum and say, instead of us rewarding for everything that you do, why don't we provide you a fixed payment upfront for each patient that you enlist into your practice, and then you, out of that payment, are responsible for providing care throughout the year or throughout a given period without any marginal reimbursement. So if I'm given, say, $2,000 to treat Jason for 2 years, for a year, then I obviously now want to manage his care. I certainly don't want to encourage overconsumption. So I'm not going to want to manipulate information or to alter things to encourage a lot of care or excessive care, because that's going to be costly, because it has to come out of the budget that I received up front. Recall that at the end of the year, my income is the difference between what I received in this upfront payment and the cost that I bear throughout the year treating this patient. Okay? So it eliminates this perverse issue of supplier-induced demand. The other thing that it can do under long-term relationships is it could encourage good chronic and disease management. I know that if I'm receiving I receive this upfront payment and I keep my patient healthy, then my patient doesn't need to come to see me, and therefore at the end of the year, I have more money. And so it could actually have this positive effect that I am more concerned about preventing disease and more costly expenditures in the future. Okay. Now, even though, again, there's some positive aspects to capitation, as there were some positive aspects to fee-for-service, there's also some important problems associated with capitation. So although the fee-for-service system is associated with sort of trying to encourage the over-provision of care or over-consumption of care, the capitation system actually has an incentive or provides an incentive to reduce the amount of care. And so these capitation payment systems have been associated with reduced quality and reduced provision. Okay? So that's a bad thing. The other thing that they are associated with is the overuse of specialty in hospital care. And why is that? Well, it's quite simple. physicians receive an upfront payment to provide general care for a given period of time. If the patient seeks care in a hospital or at the specialist, that doesn't come out of the general practitioner's upfront payment. And so an easy way to keep my money and not provide care is to send that patient off to see a specialist or to hospital. Now, that's particularly problematic in Canada because patients are fully insured. And so nobody's going to refuse this to be sent to the hospital or to a specialist, whereas if, people were uninsured or paid a part of their care, then maybe they would be reluctant to acquiesce to their physician's request. And the other thing that we know because of this reduction in quality or this perverse incentive is we're going to need efficient monitoring. And in fact, in the US, when they've set up these capitation payment systems, they have often set up review panels to make sure that this doesn't lead to too much reductions in care. Okay, so I've presented two completely opposite types of payment systems, one that pays you at the end and one that pays you at the beginning. So they both have some positive aspects, but they also have some really perverse aspects. The question is there a way that we could combine these two to sort of highlight the positives of the both while minimizing the negative aspects of both? So is there a way that I can encourage the quality consciousness of a physician as in the fee-for-service system while making physicians cost-conscious like in the capitation payment system? Okay, so can I get both quality and cost consciousness on the part of the provider? Well, the answer is quite simply yes, and that's in a mixed payment system, and for a variety of reasons. Now, before I talk about a mixed payment system, I just want to be clear on how I'm going to define it, because it's sort of a word that's used for anything that is several systems that have been mixed. And so what I'm talking about here is very much a part of the payment is capitation and part of the payment is fee-for-service. So what does it look like? Essentially, a physician would receive a fixed payment for each patient they would enlist into their practice and have to provide care for a given period of time. So that's like the capitation payment system. What's different than the capitation payment system is then, however, is once the patient has been enlisted, the physician does receive a marginal reimbursement associated with care. So it's maybe less than or equal the cost of providing of care, but they still receive some part of the reimbursement when they provide care. So that's the fee-for-service aspect. So it would be, if we were going to compare it to a capitation system, we would decrease the level of the capitation system, but then we would provide some reimbursement, okay? Now, why is this a good thing? Well, actually, what it can do is really encourage physicians to be both conscious of the costs, but also the quality of care. And as I'll talk about in a couple of minutes, it also encourages physicians to provide the right basket of care, okay? So how does this work? Well, it's actually quite simple intuitively. It's that a physician that is paid in a mixed payment system wants to attract patients. Why? Simply because patients are associated with an upfront payment. And so how do you attract patients? Well, you have to provide high quality of care. And so in order to attract patients, you provide quality of care, and so you become quality conscious. However, once you've enlisted a patient into your practice, you're only going to be reimbursed a part of the cost of providing that care at the margin. And so that makes you become cost conscious. And so I want to be good to attract patients, but once I receive a patient, more care to that patient leads to less income, and so I have to balance both this quality and this quantity to try to attract my patients, but also make money, okay, or earn income. And what we can show is that you can combine, or you can actually work out a level of reimbursement, the fee-for-service part, and a level of the capitation payment, the upfront payment, to get to this correct provision of quality and quantity. Okay. So now the mixed payment system can also encourage the right mix of care, and I think this is a really important thing. And I've heard a lot of physicians, especially ones that are in university settings, complain about the fee-for-service system for exactly this reason. So the mixed payment system can be used to encourage physicians to provide the right basket of care. Now, as you know, physicians provide a lot of services that can be easily observed by the insurance provider or by governments, and so they can form the basis of a reimbursement contract. So that's a fee-for-service. I observe that you provided test A, and I can reimburse you on that. However, we know that patients value a lot of types of care that are not observed by third parties, but that are provided by physicians. So a patient's health not only depends on the amount of tests that they get and the days that they stay in hospital, but how much their physicians are going to spend time with them, researching their case, explaining the treatment alternatives, providing them with educational materials to reduce smoking. All of these things that are valued and increase health are not reimbursed in a fee-for-service system. And so what we're doing is we're essentially punishing physicians who spend time with their patients, and that could have some positive aspects to the health. And we might want to not punish them. In fact, we might want to encourage a lot of these dimensions of care that are not easily observable and so can't form the basis of a contract. That on a per unit basis. And so if I paid a physician's fee for service, recall that in a fee for service system, you're only going to be rewarded for the volume, the things that you can write down and bill for. And so what you have at the margin is an incentive to provide things that are billable, but not to provide things that are not billable, things like time spent. On the other hand, if you go to the other opposite realm and you go a fully capitation system, now each time the physician provides a service, that chews into the capitation system. It chews into their earnings. And so now under a fully capitated system, physicians have an incentive to provide a lot of effort and time, but have a disincentive to provide things that are billable, because those things are actually going to have to be paid for with that capitation amount. So what we can show is that you can alter these upfront payments and the reimbursement rates to actually get to the right mix of care. So I can manipulate both the upfront payment and the reimbursement so that physicians actually not only provide the right quantity of care, but they also provide the right time of care or the right research or time and effort. Okay, and so I think it's an interesting thing because it could encourage physicians, or at least not penalize them for doing things that are difficult to reimburse, but we as a society enjoy. Now, coincidentally, the only large-scale study that I know that has really sort of looked at this in very micro detail is a study that was based in Quebec. And in Quebec, there was a lot of talk that physicians who were in universities were arguing, we're not being paid for administrative work. We're not being paid for teaching. These are things that society values, and you're creating a system that discourages that. And so what the government did is they allowed on a voluntary basis physicians to join a sort of mixed payment system. It's a little bit different than this, but essentially it has these components. And so what happens is that each physician was receiving it was a day thing, not a patient thing. They were receiving a fixed amount per day, and then they would receive which the other physicians who are paid fee-for-service wouldn't get. But however, once they received that payment, the fee-for-service rates that they were going to get afterwards were going to be smaller. So a bigger upfront payment, but less, the fee-for-service rates were lower. And what was shown is that in fact, what we got is the desired outcomes. And so what happened were that these physicians, even once we control for selection into the type of payment mechanism, what was shown is that it got the intended consequences, that physicians who are hospital-based did provide more time, they did do more administrative work, and they did reduce some of the billings. And so it was an interesting experiment, and it appears to have had a lot of the intended consequences. There's some questions, though, about, and we still have a lot of issues of what are the impacts of all of these payment mechanisms on health outcomes, and that's something that more and more, because of larger data sets and data sets that are tracking outcomes, are becoming more feasible. Okay. Now, quickly, because I want to get on this alignment thing, which I think is incredibly important, is that one of the nice things with this mixed payment system is it's very easy to introduce in the current system. Suppose everybody's paid fee-for-service. Now, to choose to a mixed payment system, I just have to reduce those fee-for-service rates, but also give you an upfront payment. It's not a huge move away from what we have, at least administratively. The other thing is it's very easy to add on other things that we might think are important. So one of the things that was mentioned by panelists was P4P, pay for performance. Now, pay for performance is a payment mechanism that attempts to reward physicians for good outcomes or good practices. It has a series of problems associated with that. That I don't have time to discuss here, but if you believe that a P4P system could be put into place that works well, it could be easily grafted onto a mixed payment system. The other thing that it allows us to do is it allows us to add on other things, such as the next topic, the next slide, which are things like group payment mechanisms that may be really interesting if we want to align the incentives from at the physician level with the incentives at the hospital level. Okay. So now, as we've seen in the two presentations, hospitals and physicians are essentially paid independently from one from the other. So hospitals receive, through a global budget or a DRG, receive an amount, and they're responsible for paying with that amount all of the care except the physician services. Physician services are directly billed. Okay. Now, even though the hospital is responsible for paying for all of the drugs and devices and all of these things that are used in the hospital, physicians are the ones that actually make those decisions. And so physicians directly affect the cost that the hospital must bear. Okay? Now, obviously, so this is especially true in areas where we have what are known as physician preference devices. So if you think about cardiology and all, that's the example that I'll be talking about, physicians not only get to decide, cardiologists not only get to decide whether or not they're going to put in a stent or no stent, but they also get to decide whether or not it's going to be a bare metal or a drug-eluting. And if it's a drug-eluting, they also get to decide whether or not they're going to use a Scientific America or a Johnson & Johnson. However, the prices of these stents, even within category, vary greatly. So I, as a physician, do not need to care about the prices of these things when I go to purchase them, because I have no financial incentive to actually consider the costs, okay? Now, the one thing that's really important, and this is why, at least empirically, why we should really look at alignment, is that if you track the spending on let's say, individuals who have to go to one of these cardiology labs, if you track cardiology patients over the time and the expenses over time, all of that expense is accounted for by the costs of drugs and devices. It is not because labor costs are increasing or it's costing us more on physicians. Those increases in costs in cardiology labs are all accounted for by increased costs on drugs and devices. So tackling the costs of drugs and devices is really important. Okay, whoops. Okay. Now, so if we want to make docs cost conscious about the things of like drugs and devices, then why don't we just pay them capitation like we argued, or under a mixed payment system, but include in their payment the costs associated with these drugs and devices. So instead of providing you $1,000, I'll give you a $5,000 upfront payment, but now you must use that upfront payment to pay for the stent. Now a physician would become cost conscious. There's a really important element which isn't tackled by a capitation payment system, which a lot of people aren't aware of, but is extremely important in the drug and device market. And that is that hospitals buy their drugs and devices directly from vendors, Johnson & Johnson, and in those contracts, first of all, those contracts are negotiated, so they're bilateral negotiation, and once they've negotiated those prices are actually non-linear, in the sense that the more that the hospital buys, the cheaper the per unit cost will be. So there's a discount associated with more purchases from a particular company. So what would a hospital want to do? Well, it would want to coordinate its physicians to standardize on the same types of drugs and devices. If people are relatively indifferent between Johnson & Johnson and another brand, and all of us got together and bought from Johnson & Johnson, the hospitals would get these devices at a cheaper price, and we could save money and use that to provide more care. Okay, so even if you're a nonprofit hospital in a Canadian setting, this is important, because if you reduce the price that you're paying for these things, you're going to be able to see more patients in the cardiac cath lab. So if there's pent-up demand, I think this is an interesting thing. So what happens is the costs that are borne by the hospital don't depend on each physician's actions individually, but they depend on the collective behavior or the collective choices of the hospital physician. So so one of the things that's problematic in trying to align the incentives at the hospital or the physician level are some regulatory issues. So in general, it is illegal or prohibited for hospitals to make direct payments to physicians. So they can't sort of incentivize them to use a particular stent because of anti-kickback rules. And so, there's some legal issues. The interesting thing is that there was a very large-scale U.S. experiment, the first ever done, and I'm lucky enough to be in a team of 3 people who are the only people who have access to this information. So I'll talk a bit about what we're looking at. But there was a large-scale study that was allowed by basically the Office of the Inspector General that said, we're going to allow you to put in your cardiac cath labs a team-based incentive, and that I'll discuss in a minute. And if you put in this team-based incentive, which is there to try to align the physicians and the hospital's incentives or their goals, then we are not going to prosecute. But you are going to have to follow extremely strict guidelines. They're not even guidelines, it's a strict contract that is imposed. And what we're going to do is we're going to track every single patient, and we're going to track information which is way richer than claims data. Okay, and so what they allowed is, on a case-by-case basis, the hospitals to put in team-based incentives. So cardiology teams faced a group incentive. And what they did also is collect data on 200 control hospitals during the same period, so that we really have large-scale control groups. And for those that did face these programs, we have data before, during, and after the programs, because these programs were allowed only for 1 year. Okay, so we have both panel and cross-section observation. Now, under this profit, it was essentially like a profit-sharing program. What they did is, for each group, they had they basically calculated how much that team had used, what was the expenditures of that team on drug-eluting stents last year. And they risk adjust that, and if the team spends less this year on drug-eluting stents, then the team is going to get back as a bonus half of the savings. Okay? And so it's a profit sort of sharing agreement. Okay? Now, how do the physicians get bonuses, i.e., how do the hospitals save money? Well, it can happen through 3 pathways, and some of them are good and some of them are bad. Now, the first one is that cardiologists could substitute towards cheaper drugs and devices. So instead of using the bare metal stent by Boston Scientific, I go directly to the cheaper one that's a competitor. If we do that, we're going to pay lower prices, and we're going to save money, and we're going to get a bonus. Now, that's not problematic if these things are clinically equal. So you want to think if you want to consider substitution, but you want to be very careful that if people are substituting, that they're doing so, and that's not having a perverse effect on health. The one perverse thing that could have happened is that physicians could reduce simply the quantity of stents that they would put in. That would be simply, I mean, I'm going to obviously buy less stents if I put less stents in, and so that would be something that we would not want to encourage if we think that the current level of stenting is appropriate. Okay? And the final thing, and I think this is where we really get the bang for the buck, and this is where the great incentive is that if we could somehow standardize on our treatment, that is collectively decide what is best and what we should do, if we then standardize on the drugs and devices, the hospital gets to pay a lot less for these drugs and devices. Okay? So I'll just show you the results from the preliminary results that we get. So these are tens of thousands of patients, hundreds of physicians, hundreds of hospitals. The data that we collect has all of the information at the patient and the doctor level. We observe the bonuses. We observe the price per unit of each stent. I mean, the data is extremely rich. And what we see is that once these programs, these hospitals put in these gain sharing programs, they saw a reduction in the per patient cost. So expenditures fell. Now, expenditures falling might be a good thing or it might be a bad thing. If expenditures falling are resulting from a reduction in the prices, so we bargain for better prices, it's a good thing. If it led physicians to reduce the quantity of stenting or to use low-quality stents, then it's a bad thing. And so what we want to do is to sort of look into this reduction in the cost. Now, some of the cost reduction did come from a substitution from drug-eluting stents to bare metal stents, and that's even controlling for all of the new information that was coming into the market from the clinical area. Now, so there is some of the savings that is coming at the margin from some patients being transferred from the drug-eluting to the bare metal. But where we see most of the savings is on the prices. So if you look at the price, the average price that was paid for a stent fell dramatically after this gain sharing program was put in. Now, again, that can come from 2 different sources. I could be seeing physicians hospitals pay a smaller price per stent, not because they bargained for better prices, but simply everybody went to the cheapest stent. However, when we actually look at this reduction in prices, none of it is coming from the substitution to cheaper stents. All of it is coming from these non-linear discounts and better bargaining. So when you look at the results, it is not that we're moving from drug-eluting stents to bare metal stents. It is not because we're buying the cheaper stents that we're saving a lot of money. It's because we got to bargain for much smaller prices on the bare metal stents that were supplied by Johnson & Johnson. And as a percentage of the savings, it was something like 15% of the total cost of treating these patients. And so when we were talking about where we would get extra revenue to fulfill sort of pent-up demand, this is potentially a really great source of revenue or savings. And so I'm optimistic that this is something that we should definitely consider in Canada and add on to the payment mechanisms that we might consider also.